So, Dilla Davis, thank you so much for joining me today. We've had a bit of a chat before we started recording, so I'm really looking forward to finding out more about your study. And if we could just begin with you introducing yourself, telling us a little bit about who you are and where you work.
My name is Dilla, and I work as a lecturer in nursing in University of Salford, and I've been there for past 4 years now. Gosh, how fast time flies, because all I remember is being like a penniless student and doing a PhD and searching for jobs, and then you land a job, and then you've been in the job for 4 years. Wow. Okay, so I teach across undergraduates, PhD students, yes. Yeah, and then I enjoy teaching,
I
yes.
enjoy teaching.
Before that, I was a nurse in Manchester Royal Infirmary for 15 years. And I did a few years in Manchester University as a clinical teaching fellow. I was also in the role of PEF, Practice Education Facilitator, and Education Development Practitioner as well.
Wow,
Yes,
many,
that's
many hats, many. So the reason that we come together today is to talk about your research, your project, and I think it's just an absolutely fascinating study. And so I just wanted to ask you a little bit about that. And I suppose it makes sense to begin with asking you about the question itself, the topic itself. Like, how did you decide to research this topic, and then how did you refine it into a research question?
Right. So I was, like I said, I was teaching. I was in University of Manchester when there was a call for proposals in cardiovascular research. So I wrote a proposal, a very rough draft of a proposal, and sent it off, and that's how I got the PhD studentship. So it was a scholarship. And then the first supervisory meeting itself, we kind of gleaned it down, or just filtered it down to specific ethnic groups, South Asians. And because it was cardiovascular, it was such a vast topic. So again, we went into into a kind of a specific condition that was about heart attacks, myocardial infarction. So now you have one specific ethnic group, South Asians, and then you have a specific cardiac condition, that is myocardial infarction. So what do we need to know about these two things that can connect them? So it was about lifestyle choices, so lifestyle self-management. How do they choose and prioritize their lifestyle changes? That was my question. Um, so a little bit about the geography of why these two groups. Um, every 7 minutes, someone dies of a heart attack. And the burden is carried by the South Asians. And when I say South Asians, these are the people who come from the Indian subcontinent, the Indians, Nepalis, Bangladeshis, Pakistanis predominantly. It is different from the definition given to Southeast Asians. China is not included in this, just Indian subcontinent. And so, whichever country or continent these South Asians migrate to, Indians, these people migrate to, they have the higher incidence and prevalence of heart attacks. So that was interesting itself. There are several hypotheses for this. I didn't want to go into that. But if you survive a heart attack, the doctor comes to you and say, I've got good news and bad news. The good news is that you survived. The thing is, but the bad news is that you have to change your diet, start exercising, stop smoking. This changing the diet for South Asians is very, very difficult because it is kind of embedded in ethnocultural practices. That's so much we know. So then my question was, how do they choose and prioritize these lifestyle choices when the health professional comes and tells you you have to do this, this, and this? Yes.
Interesting. So there is a certain amount that was already known about the subject, but actually, when somebody has had experienced a myocardial infarction, there are choices to be made.
Yes. Yeah.
to explore and understand what influences those choices.
Indeed, yes, yeah.
Okay, so I suppose that takes me naturally on to the next question, which is about how you can begin to find that out. So how would you design a study to answer?
Design, yes, yeah. So that was my area of concern, or that was the phenomenon I want to explore. So we for me, it was, I don't want to test a theory that was out there. For example, there were many theories on self-efficacy and all those things that is related to my subject area. Straight away, I didn't want to. And why I didn't want to, when I look back or reflect, it's because I think I always, as a nurse and from my background and my upbringing, I always kind of enticed with the stories of others. So I always wanted to listen to the story. So a testing of theory wouldn't allow that. So this was easy. This is where my interest, my passion, listening to the stories. So how's that possible is through interviews. So and then getting that interviews, we have different approaches. We have different qualitative methods for that. You have phenomenology, grounded theory, ethnography, like you yourself would know. I didn't want phenomenology because it was more of a philosophy and like interpretations of the meanings given to a phenomena, and on top of that you are interpreting that meanings. It was a bit confusing to me. So I thought, instead of a methodology, I will consider it as a philosophy in itself. Ethnography, I didn't have that time and energy to go really native, to observe them in their behavior and see the obstacles and challenges. So I took the middle ground, the grounded theory. And because my question was how and what it was how and why and what it was. It was not just to observe that phenomena. So it allowed me to go deeper, educe that understanding. Now, when I chose grounded theory, wow, I was again in a very kind of a muddle, because there were different approaches in grounded theory itself. So Glaser's classic approach, I looked at it, and then as a PhD student, I found different challenges in that, because Glaser says, you shouldn't record. I'm not saying you shouldn't record your interviews. He says it is best if you don't record the interviews. It is best you don't do a literature review at the first instance. But as a PhD student, you have to put in your ethics application, and you have to say, no, this study is unique, and it's a first study. So you can't qualify your statement and say this is a first study unless and until you do a little bit of literature search. So literature review. So that was Glaze. And also he had a little bit of objectivist view to data, the way the knowledge is discovered within the interviews, which I couldn't understand. It didn't feel right with me. Let's say in that way. So, and then Strauss and Corbin's interpretivism, let's say, is their approach with their axial coding. And again, for me, it was not just interpreting something, it was more than that. And then Sharma's came in, and I totally fell in love with Sharma's. I can't tell you, even now I have that goosebump. So her flexibility allowed for others, for a novice researcher, it might find a bit difficult, because she doesn't give any guidance as such regarding how you want to approach your coding or your analysis of that data as such from the emergence of the categories. So but for me, it was freedom. It was my footsteps in the methodologies that gave me that. For me, it gave me that freedom. So I chose Sharma's, and Sharma says knowledge is not static. It is always emerging and developing. And beautifully, she says, it is co-constructed with the researcher and the participant. So here I have my participant voices. I have my own observational feed notes and memos about that interviews. And with both amalgamation of both, I constructed my theoretical categories. It was very difficult because I needed somebody to endorse me and say, your coding is correct, your category is correct, but you won't get that endorsement or validation. It's your own journey. And funny enough, so that was my approach overall, and how I designed my research, my research around this. And I was very particular that I follow Sharma's, but make it my own as well. Uh, Other researchers have brought in Axel coding in, and Shamas agrees. You can, if you're comfortable with that, you can. But for me, it was just open coding and focused coding. That was it. And then developing construction of those theoretical categories. And from that categories, I formed a kind of a substantive theory. So for me, it was from those categories, but the way I formed that theory, the explanation of how and why they chose and prioritized their lifestyle changes. So their family was important, their religion was important, their culture was, or the group was important. So anything, in any advice or recommendation that challenges their rites and rituals related to these three fears, they would not listen to, or they will not adhere to, or they would shake their head and say, or they will nod their head and say, we will listen to, but they wouldn't follow it. For example, exercise or cardiac rehab classes. The health professional might say, please come in for the cardiac rehab classes. It is between 9 o'clock till 4 o'clock. But the person might say, that's when I do the school run. So I'm committed to that. They give priority to that instead of giving priority to their health. So that for me was a shared efficacy. It was not the capacity and capability, like Albert Bandura says, the self-efficacy theory. If you believe in something, you can go get it. That's it. But here they had the capacity and capability, but still they prioritize something else that they valued rather than their health. And that I termed as shared efficacy.
That's really fascinating. So actually it speaks to those of us who are kind of interested in how we frame those options. It's that thinking about where it fits in somebody's kind of sets of priorities.
It is, yes. So so people do ask, so how does your shared efficacy fit in with the health professional encounter to someone who says my priority is this school run? So I said, if you're going in the car, park 5 minutes away so that you can get that 5 minutes of walking exercise, embedding that. So if someone says, I want to go for my grandson's wedding, see that as a goal instead of losing weight, maybe. Or that kind of walking tolerance without getting chest pain. So instead of that, which is not related to their immediate practice, family practice and rituals, put that as a goal, pull that as a goal.
That's really interesting, because I suppose the health advice is very much sees the patient as this kind of little island.
Yes.
Not connected, not part of a kind of web of attachments and culture, family, and actually that it sounds like it totally makes sense that that's why it would fall flat, because that's not how we are. We're relational beings, aren't we? And some of others, for some of us, that's really embedded in culture. So
indeed, yes. And my greatest kind of endorsement came when Kathy Sharma, I was able to present before her a few years ago. There was a conference in which she had to do a keynote speech. So I was able to present my research, and what greater. And then I had a small handbook prepared for my PGR students, a peep into grounded theory it was called, and she signed that copy. What great validation.
Because you read something that I think is really, like, it really resonates with me, which is about like which is about being a research geek, really. I think we have to be like, I hold my hand up and say, like, there are people who have inspired me along the way, either through the way that they think about things or their activism in seeking to get an answer to a question that seems to be unanswerable, or their creativity, or their communication skills. So I love the way you talk about Shahmaz, and I that's the way that you sort of you're fangirl Kathy. So what I'm going to do, I think, is I'm going to have to put a link to some reading around Shahmaz as well, next to the links to your paper, so that anyone watching this video who has not had the joy of coming across her work yet can do further reading. So, Dilla, I'm really mindful of time. I just, we're obviously not going to cover everything about your study in this short space of time, and I will provide links for people to read more about it. But before we finished, I just wondered if you could reflect on what it was like for you to kind of make a transition. Well, it's not a transition really, because you are still a nurse, but to become a nurse who does research.
I think it is part and parcel of being a nurse, because you find out what is happening in a person's life, and that's what you do as a researcher, as a qualitative researcher, let's say. I'm partial to qualitative researchers. So that kind of a inquiry mind you have as a nurse. And as a researcher, what you're doing is polishing it up and refining it in a way that is conducive to both the participant or the patient and yourself as a nurse. So you get the skills, for example, reflexivity. As a nurse, you are trained to be a reflective practitioner. Reflect on your practice. It is on practice, for practice, and all those but as a researcher you become reflexive, and that is again to me a very deep understanding about why you have behaved in such a way. It's about your biography and your history, and how that influences the decisions that you make as a researcher. And that reflexivity, you can take it back as a nurse as well. You listen more deeply. And that deep, not just to give a response, to understand what is happening. And that skill you get, and that's a very valuable skill that you get.
So I hope I answered. Perspective. Yeah, no, it's a wonderful answer. And I think it sort of makes me think that it's not so much a shift as a deepening. It's not so much as like you've leapt from one role to another.
No,
which is a deepening of your understanding of what you were already doing, and applying it in such a way as to improve practice, to enhance practice.
Yes,
that makes sense. I'm going to close the interview now, but I do really encourage anyone watching to click on the links to read the full reports of Dilla's work. It's really phenomenal research, not phenomenological research. And I'd like to just thank you again very, very much for giving of your time so freely to come to talk to me today. It's very much appreciated. I'm going to stop the recording now, if I can. It never wants to allow me to. It always wants me to carry on and record more. Oh, where's it go? There we go.